Hello, this short movie is about the Mammographic Quality Standards Act, or MQSA. Now, why do you need to know about this? Well, it's in your core exam. Part of it will be in the certifying and MOC exams by the American Board of Radiology, but also if you're in any form of practice in future where you will be interpreting mammograms, you need to know at least about the elements of it, even if you're not the physician who is primarily responsible for it. I do understand this is perhaps not the most exciting topic in radiology to be learning about, but it is important at least to know some of the key elements. So sit back and relax, and I'll try and make this as painless as possible. So MQSA is all about quality. There is increasing emphasis on quality in radiology across all modalities, but there is nowhere which has anywhere close to the federal mandates for quality that mammography has. MQSA came into law in 1992 under public pressure to improve the quality of mammographic facilities. Although it passed into law in 1992, it mandated that all mammographic facilities be certified by the FDA and accredited by an FDA-approved body no later than October of 1994. The aim of this bill was to both improve and standardize mammographic quality of both the images and the interpretation across the country. So all mammographic facilities, such as Dartmouth-Hitchcock Medical Center, have to be accredited every 3 years. They're accredited, the ACR performs the accreditation process for us in some states named here. It's actually a state body rather than the ACR. And these mammograph facilities are then certified by the Secretary of Health and Human Services every 3 years. In addition to this, there is an annual inspection by the FDA of every mammographic facility. Now note that MQSA covers film screen mammography, digital mammography, and tomosynthesis. Although note that tomosynthesis images are not currently sent to the ACR, just film screen and digital images. But MQSA does not include stereotactic biopsies, ductography, needle localization, sentinel node procedures, breast ultrasound, breast MRI, or nuclear breast imaging. However, the ACR does have a completely separate accreditation process outside of the ACR, outside of MQSA for breast ultrasound, breast MRI, and stereotactic biopsies, and institutions can be accredited for those areas. Right, so the FDA inspection team comes in every year to every mammographic facility. Let's just go through quickly what they look at. So the FDA will check the QA/QC program that's in place in your facility. They will check the qualifications of all the personnel, so that will include the physicians, the technologists, and the physicists. They will check your audit and outcome records. We're going to talk more about these in a separate video. They will look at random patients' reports and images, and they will also confirm that we have adequate patient and physician notification systems in place. Additionally, they're going to look at the physicist survey results, and then they evaluate our equipment. There's a whole big list of things that they evaluate, but these include things like the paddles, our dose calculation, the quality of our phantom, our collimators, and so on. Now, what about the ACR accreditation program? So as I said, this is every 3 years. The ACR accreditates the mammographic unit, so each mammographic machine is separately accredited by the ACR, where the FDA comes in and does the whole facility. And so we have to submit a bunch of different forms about each piece of equipment we have. Again, the personnel qualifications, including such elements as our CME credits in mammography. We have to send test image data, and we have to send the reports of our QCs that are performed in the multiple different areas that we'll talk about. Again, as I said, that we have to send everything for each individual mammographic unit. So for every mammographic unit, we have to provide to the ACR a breast phantom image, which is assessed for image quality as well as a dose evaluation. it's important to remember that the dose should be less than 300 millirads or 3 milligray per view. This is an important number to remember. We provide 2 normal mammograms from all screen film and digital units. These should be the best images. The technologists and the supervising radiologist usually work very hard to make sure that these are the perfect mammographic images in terms of positioning, exposure, no skin folds or other artifacts. And we send to the ACR a CC and MLO set from one patient who has predominantly fatty density breasts and one patient who has extremely dense breasts. When the reviewers at the ACR look at these images, they're going to review a number of different criteria. How well the patient's positioned. Does the compression appear optimal? Is the exposure appropriate? Is it adequate contrast, sharpness, a low enough level of noise? Are there any artifacts present? And is the exam identification in terms of the patient name, medical record number, date, facility, and as well as the technical parameters appropriate on the image. Seeing as Mqsa is all about quality, I wanted to try and clarify a couple of things that I know I find very confusing, and I suspect some of you may, and that is the difference between quality assurance, quality control, and quality improvement. And people talk a lot about these 3 different processes, and sometimes the terms get used interchangeably, but they are really different but interrelated processes. And perhaps rather than a pie diagram, perhaps they're better thought of like this, that quality improvement is really the overriding process over quality control and quality assurance. So let's start with quality improvement. Quality improvement is really proactive, and it really aims to improve the quality of the care and the services that in our case we're performing for patients. Obviously quality improvement covers manufacturing and a whole slew of other things. And so it aims to develop a system or a process or improve in some way how well a system functions. Quality improvement is based on facts. It has a very clear scientific methodology which is used to analyze the current situation and improve the systems in future. So a couple of examples from radiology of QI. The process of us trying to decrease the turnaround time for screening mammography, in other words, the time from when a patient has a scan to when they're holding a report in their hand. Or the process of developing a pre-screening protocol to try and reduce the incidence of contrast allergy. Quality assurance is really the processes that have been developed through the QI process, the monitoring that is put in place, and the preventative processes that have been developed in order to try and improve quality and prevent errors. So it's all about collecting the data, evaluating the data. Again, it's related to systems, and there's some form of a tracking and reporting function associated with it. So to give you a couple of examples. So at DHMC, the contrast reporting of adverse events, and then the conferences where people sit down and discuss events that have been reported through contrast, monitoring waiting time, monitoring repeat imaging rates, correlating our mammographic biopsies with pathology, how fast the reports come out, and so on. And finally, quality control is really retrospective. So both QI and QA are prospective, QC is retrospective. So QC measurements may involve measuring compliance with a set standard, detecting an error in a specific measurement, and in these you only take action when a measurement falls outside of the range, otherwise it's just being recorded. And this really is not a system function, unlike the other two. Again, unlike QI and QA, this really may involve an individual or a piece of equipment rather than a system. So some examples of QC: checking for artifacts weekly, the weekly checks of the mammographic equipment, preventative maintenance of equipment, monitoring of radiation doses, appropriate labeling of images and specimen containers, and so on. These are all QC. So coming back to MQSA includes multiple aspects of both quality assurance and quality control, but it does not include quality improvement. So credentialing of physicians and technologists, audits, patient notifications, evaluating reports, evaluating equipment, these are all QA and QC. All right, having got through that, let's move on to the requirements for physicians to be able to read mammograms.
All right, so what are the requirements for you to be able to start to read mammograms? So the initial requirements, you have to have medical license, you have to be board certified in radiology, you have to have had documented 3 months of mammography training, including physics, and 60 hours of education, which is easily accomplished during most residency programs between didactic sessions and time on the workstation, including 15 hours within the past 3 years. Now, the one that tends to get people and is often misunderstood is that you have to have done 240 second read exams within a 6-month period in the 2 years prior to graduation. Okay, so it's not 240 exams in the last 6 months, which is what residents often take it to be, but it is 240 exams within a 6-month period. So perhaps those 240 exams in your 3rd year, and if you've accomplished all your 3 months of mammography by the end of the 3rd year, you would not have to do any mammography within your 4th year period at that time.
Now, the continuous requirements are a little bit different. You have to read 960 exams over within a 2-year period. You need to get 15 hours of Category 1 CME within a 3-year period, and that has to be specific for mammographic imaging. It can include breast ultrasound, breast MRI, and regular mammography. And for any new modality that becomes developed, such as tomosynthesis, you have to have an additional 8 hours of Category 1 CME in that area, and sometimes that's a little bit more challenging to get. So before you are allowed to read tomosynthesis currently, institution, you do have to have that additional 8 hours, even if all your other general CME hours are up to date. There are many places that run little one-day courses that you can get that, and you can get them online. The technologists, the physicists, and the FDA inspectors all have to be credentialed. They have a similar list of credentialing elements, including CME and experience, but I'm not going to go into them here. So let's start going through some of the quality control aspects that need to be done in mammography. Again, these are part of MQSA. These are checked by that FDA inspection every year. So there are still some institutions doing screen film QC, so I'm just going to briefly mention some of the elements that are particular to screen film that we don't talk about in digital. Daily, the darkroom has to be checked for cleanliness, and then is a QC which is done on the processor. Once a week, there are phantom images obtained. The screens, the screen films are checked for cleanliness, and the viewing conditions for the mammography interpreters in terms of how bright the view box lights are, etc., are checked. For digital mammography, which obviously is what most institutions are doing now, there are a number of checks that are done weekly. The uniformity of the detector, the contrast resolution or the signal to noise ratio, the contrast to noise ratio, the compressor thickness indicator, the soft copy workstation check, and the printer quality control check. That runs like a standard phantom through the laser printer. If you look in your department, you're going to find a folder that one of the assigned technologists on specific days of the week goes in, and they usually schedule these on different days, but a specific technologist usually will go in and do these and record the results every week. And these charts are sent off to the ACR every 3 years, as well as being looked at by the FDA inspectors. Now, one thing to note is that all of these QCs are manufacturer specific. I'm showing you here the Hologic ones, which we have, and if you have a different type of equipment in your institution, these may be slightly different, but they all contain pretty much the same factors. For Hologic, we also weekly have to do a calibration, we have to do an artifact evaluation, and we must acquire phantom images on both the regular digital units and the tomosynthesis unit. We have a specific 3D phantom for the tomosynthesis unit, and we're looking at fibers, specs, and masses. So this is an example of a breast phantom. It's basically a block of plexiglass, and embedded within that plexiglass in the center here are the fibers, the specs, and the masses. And for a phantom to pass ACR MQSA accreditation, you need to be able to see 4 of the 6 fibers, 3 of the 5 spec groups, and 3 of the 5 masses. Now, any individual manufacturer might have higher quality control standards for their own equipment. This is a diagram of the phantom. So here are your fibers of different sizes, here are your spec groups, and then obviously here are your masses. So we don't have to see every one of those, but we do have to see the majority of them, as I detailed before. Here's an example of an image from the breast phantom performed for MQSA, which just about passes it. You can see here that we have 4 fiber groups, 1, 2 of the specs here, and just about the 3rd one, and then we have 4 of the masses. There are a number of other QCs which are done monthly, quarterly, or biannually, which are listed here. So monthly, they have to visually inspect the equipment to make sure things aren't falling off. Quarterly, do a repeat analysis of images. Biannually, there's a compression test, and for the Tomo, geometric calibration test. Again, these are manufacturer specific. Once a year, the physicist does a complete survey of the department, which is documented for the FDA inspection, and preventative maintenance is done on the equipment. Part of MQSA includes an evaluation of our reports. MQSA is very specific about what needs to be included in those reports for it to be considered an adequate report. We must make sure, so they will randomly look at a number of patients' reports. They must include the name, the medical record number, the date, and the interpreting physician. They must include the text of the BI-RADS assessment, and there's optional for the category. In other words, your final interpretation must include text such as interpretation, highly suspicious for malignancy. Whether or not you choose to include the term BI-RADS category 5 in it is up to you. But again, those BI-RADS assessment text should be the standard text within the BI-RADS lexicon. You must include a description of the breast density, again using the BI-RADS criteria, and you must include a recommendation for further management, be it repeat screening, additional imaging, and so on. And you must address the clinical question within your text. So if the patient came in with a palpable mass, you need to have somewhere said that you correlated any the clinical finding with any mammographic finding, or if there was no mammographic finding correlate. There are rules governing the report and notifications to the patient physician. A written report must be received by the physician within 30 days and a lay report to the patient within 30 days. Patients who are self-referred without a physician on record get both reports. For patients in whom there is a BI-RADS 4 or 5, a suspicious or highly suspicious finding, the definition is that a report should go to the patient as soon as possible, and this is generally felt to be within 3 to 5 days, although there is no specific period identified. Institutions are required to keep reports and images for 5 years, and they must keep them for 10 years if there is no more imaging obtained at that medical center. If a patient has further imaging performed at another institution, the original institution must transfer the images either digitally or in hard copy upon request, but they can charge the patient for the costs involved of image copying or image transfer, or FedEx to send the images. We must show that there is a system for complaints, and we have to keep any complaints for 3 years. Just a couple more details about the MQSA regulations for the equipment we use. There are extensive and very specific standards for MQSA for the equipment. Primarily, it must be dedicated mammo equipment. In the old days, routine radiographic equipment was used in some centres for imaging the breast. That the dose must be under 3 milligray per view in the phantom, and there are a number of very specific requirements involving the receptor size, the magnification, the compression, the technique, the auto-exposure control, and so on. So what happens if an institution fails its MQSA certification or its ACR accreditation? There are very serious consequences for non-compliance with MQSA. A level 1 non-compliance basically means that the mammographic facility is shut down until these are corrected. This can be due to unqualified personnel, be they technologists, physicians, or physicists, a poor quality control program, or a radiation dose greater than 4 milligrays exposure for the phantom measurement. For level 2 non-compliance, they have 30 days to correct this before they're being shut down, and these might include something such as lacking audit, a radiation dose that's 3 to 4 milligrays per exposure for the phantom, or a failed phantom image from quality control purposes. As well as being shut down or having time to correct, there are fines associated with non-compliance.